Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights for the month of July 2007. Please note that the full text of all articles may be viewed online at ajp.psychiatryonline.org, including all author affiliations and disclosures. This month will begin with a group of articles on the association between antidepressants and suicide. Then we'll highlight two articles on genetics. The first is by Ian Jones and colleagues, and it presents evidence of linkage between bipolar puerperal psychosis and chromosome 16. The second is by Daisuke Matsuzawa and colleagues, reporting an association between the human PIC1 gene and methamphetamine psychosis. These articles are discussed in an editorial by Francis McMahon. We'll also present highlights of this month's Treatment in Psychiatry feature by Jonathan Bisson and colleagues, entitled Early Psychosocial Intervention Following Traumatic Events. Then we'll turn to several articles on schizophrenia. Two describe abnormalities of white matter, and these are discussed in an editorial by Kelvin Lim. We'll also highlight two articles on the treatment of early psychosis, with an editorial by Michael Green. Let's begin with the studies on antidepressants and suicide. The first is by Gregory Simon and James Severino. The title is Suicide Attempts Among Patients Starting Depression Treatment with Medications or Psychotherapy. The data come from Group Health Cooperative, a mixed-model prepaid health plan. Claims for prescriptions and outpatient visits were used to identify all new episodes of antidepressant treatment for depression from 1996 to 2005. Visits for psychotherapy were included. Inpatient and outpatient claims were used to identify all hospitalizations or emergency room encounters with a diagnosis of definite suicide attempt or possible suicide attempt in the 90 days before the initial antidepressant prescription or psychotherapy visit, and in the 180 days after the visit. A total of 109,000 individuals were treated for depression during the study period. The claims records revealed that suicide attempts were most common in the month before treatment began, next highest in the first month of treatment, and still lower as treatment continued. This progression occurred for both medication and psychotherapy. Among adolescents and young adults, the incidence of suicide attempts was approximately twice as high as in the entire group. Nevertheless, this younger subgroup showed the same time pattern, with the highest incidence of suicide attempts in the month prior to treatment and a decline after the beginning of treatment. A decline in suicide attempts after the start of antidepressant treatment was also demonstrated by Robert Gibbons and colleagues. Their findings appear in the article, Relationship Between Antidepressants and Suicide Attempts, an analysis of the Veterans Health Administration datasets. The study included more than 225,000 veterans who experienced depressive disorders in 2003 or 2004. About 1/4 were not treated with an antidepressant. About 1/2 received a single antidepressant, usually an SSRI. The remaining 1/4 received multiple antidepressants. The rate of suicide attempts was significantly lower after treatment with an SSRI than before treatment. In addition, the number of suicide attempts was only about 1/3 as high in patients taking SSRIs as in patients who did not receive antidepressants. The analyses were repeated for different age cohorts, and they yielded similar results. Even patients in the 18 to 25 age group who were taking SSRIs had a risk of suicide attempts about 1/3 as high as in patients not receiving antidepressants. The number of suicide attempts decreased after treatment, but the difference fell short of statistical significance. Similar results emerged for antidepressants that were not serotonergic, including tricyclic antidepressants. In addition, among patients receiving multiple antidepressants, the data showed no evidence of a higher risk of a suicide attempt after addition of an SSRI to the treatment regimen. This suggests that SSRIs do not preferentially increase risk for patients with particularly severe illness or resistance to treatment. The next article addresses how suicide acts are identified. The authors are Kelly Posner and colleagues. Their report is titled Columbia Classification Algorithm of Suicide Assessment, Classification of Suicidal Events in the FDA's Pediatric Suicidal Risk Analysis of Antidepressants. Before the FDA's analysis of pediatric antidepressant trials, it commissioned a study by Columbia University and the New York State Psychiatric Institute to classify all events that could represent suicidality. The resulting instrument is called the Columbia Classification Algorithm of Suicide Assessment, or CCASA. It uses definitions of suicidality derived from empirical findings on the phenomenology of suicidality, in addition to predictive and risk factors that have been identified. The algorithm has 8 categories that distinguish suicidal events from non-suicidal events and from indeterminate or potentially suicidal events. For the FDA analysis, the adverse events from 25 pediatric antidepressant clinical trials were identified by the pharmaceutical companies that conducted the trials. More than 400 adverse events were reported. These events were randomly assigned to independent expert suicidologists, and 3 of the 9 raters evaluated each adverse event with the new algorithm. The overall reliability among the raters was excellent. 12 cases that were originally identified as potentially suicidal events by the pharmaceutical companies were classified as not potentially suicidal by the CCASA raters. On the other hand, they identified 26 new possibly suicidal cases that were not originally included in this category. The Columbia algorithm identified more potentially suicidal cases, but the number of definite suicide attempts was lower. Agreement between the algorithm and the pharmaceutical companies was good for the nonspecific pool of all events that could possibly represent suicidality, but the agreement on specific occurrences was relatively low. The companies rated 45 events as suicide attempts that CCASA raters did not. Thus, reclassification with CCASA would indicate less risk of suicidality in depressed pediatric patients. An editorial by Dr. David Brent discusses the findings of the articles by Simon, Gibbons, and Posner. Please refer to the July issue for the full editorial. Now we'll turn to the articles on genetics. The report by Ian Jones and colleagues is titled Bipolar Affective Puerperal Psychosis, Genome-Wide Significant Evidence for Linkage to Chromosome 16. The authors selected families with bipolar disorder in which there was at least one family member with a manic or psychotic episode with an onset within 6 weeks of childbirth. Individuals were classified as affected if they had been diagnosed with bipolar I disorder, bipolar II disorder, or schizoaffective disorder bipolar type. 54 affected sibling pairs were identified. The authors conducted a genome scan with nearly 500 microsatellite markers. A genome-wide significant linkage signal was observed on chromosome 16p13, and a genome-wide suggestive linkage was observed on chromosome 8q24. The second genetics article is by Daisuke Matsuzawa and colleagues. The title is Identification of Functional Polymorphisms in the Promoter Region of the Human PIC1 Gene and Their Association with Methamphetamine Psychosis. PIC1 stands for Protein Interacting with C-kinase 1. The gene plays a role in the targeting and clustering of the dopamine transporter, which is the primary target site for methamphetamine. A comparison of 200 methamphetamine abusers and healthy subjects identified 4 highly frequent single nucleotide polymorphisms, or SNPs, 2 in the promoter region of PIC1, 1 in intron 3, and another in intron 4. One of these was significantly associated with methamphetamine abuse in general, and 2 others were associated with subjects who had a spontaneous relapse of psychosis. Francis McMahon provides historical context for these articles in the editorial, A Success at the End of an Era and a Glimpse of Things to Come. The history of genetic studies of bipolar disorder can be divided into eras distinguished by the methodology that drove the big advances. The first era started roughly with Kraepelin in the 1890s. It rested on descriptive phenomenology and established the definition of what geneticists call the bipolar phenotype. The second era started with the early twin studies in the 1930s and relied on genetic epidemiology to show that bipolar disorder was largely a genetic disease. The third era, which we can call the Linkage Era, probably began with the first genetic linkage study of bipolar disorder in the late 1960s, but did not really get underway until molecular markers became available for genetic mapping in the late 1980s. The Linkage Era is now passing and may soon be overshadowed by the findings that are emerging from genetic association studies, especially the genome-wide studies that will come to dominate the field in the coming years. Linkage studies survey the genomic landscape and reveal only the general topography, and they depend on the co-segregation of genetic markers with disease within families. On the other hand, genetic association studies depend on the detection of markers whose alleles are more or less common among individuals with a disease compared to a group without the disease. Linkage studies work best when a single gene plays the major role in disease risk. Association studies can detect genes with smaller effects. There is a special case where linkage can produce strong signals, even in the face of substantial genetic heterogeneity. When the phenotype can be redefined in such a way that the revised definition of a case encompasses a narrow and more genetically homogeneous group, linkage studies may be able to detect a robust signal. This approach has been used with some success with forms of bipolar disorder that differ by clinical features, such as mania at the onset of bipolar disorder. Now Jones et al. Have shown that a postpartum or puerperal onset substantially increases the evidence of linkage to regions of chromosomes 16 and 8 that have been implicated in other studies. Episodes of bipolar disorder that occurred during the immediate postpartum period typically are severe episodes characterized by psychosis and occasionally by violent or suicidal behavior. Since the postpartum period is accompanied by a host of psychological and physiological stressors, it is perhaps not surprising that vulnerable people might suffer onset or relapse of bipolar disorder during this time. Nevertheless, the fact that this clinical feature strongly implicates one or two specific chromosomal regions implies that bipolar disorder with postpartum onset may indeed be a genetically more homogeneous illness than bipolar disorder more generally defined. Also in this issue, Matsuzawa et al. Provide a taste of the power of genetic association studies to detect alleles that contribute to psychiatric disease, in this case, methamphetamine psychosis. Previous studies have shown that methamphetamine primarily targets the dopamine transporter, whose trafficking is controlled in part by protein kinase C-alpha binding protein, encoded by the gene PIC1. This gene resides in a region on chromosome 22 that has been widely linked to schizophrenia, the psychotic features of which resemble those seen in methamphetamine psychosis. The authors hypothesized that genetic variation in PIC1 may contribute to the risk of methamphetamine abuse and its associated psychotic complications. After genotyping markers in and around the gene in methamphetamine abusers and healthy comparison subjects, the investigators found that several markers and haplotypes are associated with methamphetamine abuse, psychosis, and spontaneous psychotic relapse. The candidate gene approach may follow linkage approaches into obsolescence as denser sets of markers for genome-wide association studies become available, but there will probably always be room for good hypothesis-driven candidate gene studies, especially for phenotypes that might not easily provide the large sample sizes needed for genome-wide studies. This concludes the editorial by Francis McMahon. Please refer to the July issue for the full version and the articles by Jones and Matsuzawa. Now let's turn to this month's Treatment in Psychiatry feature by Jonathan Bisson and colleagues. The title is Early Psychosocial Intervention Following Traumatic Events. It begins with a hypothetical case. Bill was a 35-year-old journalist working for a local radio station. He was sent to report from the scene of a bomb attack that resulted in several fatalities. What he witnessed at the scene distressed him greatly. Immediately afterward, he began repeatedly to re-experience what had happened, leading him to avoid either discussing or thinking about it. He continued to work, but lost interest in things around him. He became withdrawn, irritable, and hypervigilant. These symptoms rapidly diminished over the first few weeks, but then 1 month after the attack, they began to increase again for no apparent reason. Recent, well-designed research indicates that the rates of problematic reactions to trauma are lower than many imagined. It has been estimated that post-traumatic stress disorder occurs in around 14% of those exposed to traumatic events, but PTSD is not the only post-traumatic psychiatric disorder. Depression, anxiety disorders, substance misuse, and adjustment disorders are also common. Formal therapeutic intervention for everyone exposed to a traumatic event is not supported by the evidence from randomized controlled trials. However, there does appear to be a consensus that ignoring the early post-trauma period altogether would be misguided. For instance, shortly after a traumatic event, it is important to provide those affected with empathic, practical, psychological support. In addition, provision should be made so that individuals can obtain appropriate early support after a traumatic event. In the case presented, despite Bill's significant initial distress, there was no indication for an early formal intervention. Bill's employer was aware of the increased risk of psychological trauma in journalists and had introduced a peer support system. Within a few days after the incident, a peer supporter met with Bill, noted Bill's level of distress, and reminded him of the common reactions following traumatic events. They also discussed mobilizing Bill's usual forms of coping, avoiding potentially problematic coping responses such as heavy consumption of alcohol, and accessing support from those around him. When Bill's symptoms worsened a month after the bombing, he was concerned that his response might require more help. Through his company's employee assistance program, he was put in touch with a clinician 6 weeks after the traumatic event. The clinician concluded that Bill was suffering from acute PTSD and that he needed treatment. Bill was treated with 10 sessions of trauma-focused cognitive behavior therapy. Once a therapeutic relationship was established, the trauma itself was discussed in great detail, and Bill was required to listen to tapes of the sessions as homework. He gradually habituated to the fear associated with his traumatic experience. By session 7, Bill had improved sufficiently to be able to visit the scene of the attack with his therapist. This helped Bill reappraise what had happened and generate a less distressing memory of the actual scene. At the end of therapy, Bill reported very few traumatic stress symptoms and was returning to his former activities. Now we'll turn to 2 articles that focus on white matter abnormalities in schizophrenia. The report by Monty Buxbaum and colleagues is titled, Relative Glucose Metabolic Rate Higher in White Matter in Patients with Schizophrenia. The article by Thomas Whitford and colleagues is entitled, Volumetric White Matter Abnormalities in First Episode Schizophrenia, a longitudinal tensor-based morphometry study. The articles are discussed in an editorial by Kelvin Lim titled Connections in Schizophrenia. The editorial points out that only recently has much attention been given to white matter in schizophrenia. The primary research focus has been on gray matter, where the neuronal cell bodies, dendrites, and synapses are located. White matter provides wiring between cortical regions. Structural neuroimaging has shown volumetric abnormalities primarily in gray matter, but also in white matter as well. Functional neuroimaging has uncovered metabolic and activation abnormalities of gray matter, but there has been no comparable technique to demonstrate the activation of white matter. However, because of the organization of axons within bundles of myelin sheaths, the integrity of white matter can be analyzed in a different way. Diffusion tensor imaging measures the self-diffusion of water molecules within tissue and can provide quantitative information about white matter organization. Nearly 10 years ago, the first diffusion tensor imaging study of schizophrenia was published. It provided the first in vivo evidence of disorganization of white matter in schizophrenia, possibly resulting from myelin abnormalities. Animal studies have shown that diffusion tensor imaging is sensitive to changes in myelin's integrity. Subsequent reports of reduced expression of myelin-related genes in frontal brain tissue and a reduced number of oligodendrocytes in subjects with schizophrenia give a plausible explanation for these findings. It has been proposed that schizophrenia is a problem of abnormal interactions between brain regions. Since white matter is the anatomical manifestation of the brain's connectivity, the identification of morphological and neurobiological abnormalities in white matter lends further support to the hypothesis that there is a problem in brain connectivity in schizophrenia. Positron emission tomography using fluorodeoxyglucose has demonstrated reduced glucose metabolism in the frontal cortex in schizophrenia, but has not been used to examine white matter metabolism. Buxbaum and colleagues examined relative glucose metabolic rate in both gray matter and white matter during a cognitive task in 67 unmedicated patients with schizophrenia and 103 healthy volunteers. They found a lower glucose metabolic rate in the frontal gray matter of the schizophrenia patients compared with healthy volunteers. The patients also had a higher white matter metabolic rate in several regions: the corpus callosum, the internal capsule, the superior longitudinal fasciculus, which connects the anterior and posterior regions of the brain, and the uncinate fasciculus, which connects the temporal and frontal cortices. Myelination of axons permits the action potential to be transmitted more rapidly and with a lower energy expenditure than in an unmyelinated axon. Thus, a finding of white matter hypermetabolism is intriguing because it suggests a problem in the intrinsic signal conduction or in the nature and volume of the signal. In the second study, Whitford et al. Examined white matter volume by using magnetic resonance imaging to obtain structural brain scans. They used voxel-based morphometry to examine a cohort of 41 first episode patients with schizophrenia and 47 healthy comparison subjects. The baseline data showed deficits in white matter volume in the frontal and temporal lobes and an increase in the frontoparietal junction. Follow-up scans at 2 to 3 years were available for about half of the subjects. The patients showed greater loss of white matter volume bilaterally in the inferior temporal cortex than in the healthy comparison subjects. With the advent of non-invasive in vivo neuroimaging, tissue volume abnormalities were among the first findings in schizophrenia. Analytic approaches have evolved from purely manual strategies to those with minimal user interaction. Early studies focused on specific brain regions. Because of the labor-intensive quantification process, the whole brain examination has allowed less anatomically biased studies that provide us with a broader perspective on how much of the brain is involved. The Whitford study extends this view by demonstrating baseline involvement of white matter in frontal, temporal, and parietal regions in first episode patients and continued progression in temporal regions. Future studies will need to take into account these convergent neuroimaging findings, integrating and extending them in multimodality experiments with the same subject. For example, the anatomical findings from diffusion tensor imaging and morphometry need to be integrated with functional studies. Diffusion tensor imaging tractography has generated much excitement because of its impressive depictions of white matter tracks, which are consistent with known anatomy. Studies integrating functional MRI and diffusion tensor imaging would be able to address the contribution of anatomical connectivity to the observed abnormalities in fMRI activation between different brain regions. If we interpret the increased white matter metabolism as an indication that the white matter is stressed, it would be helpful to better understand the nature and causes of this stress. Proton magnetic resonance spectroscopy of white matter has found reductions in N-acetyl-moieties, which are generally thought to be an indication of neuronal viability. Phosphorus spectroscopy can provide even more direct information about energy stores and metabolism. Reduced myelin would directly affect the velocity of neuronal conduction and potentially affect neural synchrony, which then could be measured with electrophysiologic techniques. Genomics is undoubtedly another important factor that will need to be integrated. A current example is the evolving story of neuregulin-1 as a susceptibility gene for schizophrenia. There are now associations between neuregulin-1 and multiple mechanisms currently believed to be important in this illness, including the regulation of radial glia, neuronal migration, neurotransmitter receptor expression, oligodendrocyte development, and the onset of puberty. Although many of these powerful techniques cannot be used in humans in vivo investigations, the use of animal models can allow us to examine the contribution of specific molecular mechanisms to observe pathologies. A recent report described a study in which the signaling of neuregulin-1 and its receptor was blocked in oligodendrocytes in mice, resulting in a number of the pathologies seen in schizophrenia. The mice had more oligodendrocytes but had thinner sheaths, resulting in slower electrical conduction. In addition, there was evidence that the mice had altered sensitivity to dopamine. This concludes the highlights of the editorial by Kelvin Lim. Please refer to the July issue for the complete version and the articles by Buxbaum and Whitford. Now we'll feature two reports on the response of early psychotic illness to antipsychotic drugs. Joe McAvoy and colleagues present the article, Efficacy and Tolerability of Olanzapine, Quetiapine, and Risperidone in the Treatment of Early Psychosis, a randomized, double-blind, 52-week comparison. The 400 patients in this study had been ill with schizophrenia or other psychotic illness for less than 5 years and had limited exposure to antipsychotics. The primary outcome measure was the rate of discontinuation, and approximately 70% of each group had discontinued treatment before the end of the 1-year trial. Nevertheless, more than half the patients met the criteria for response at some point. Patients in all 3 treatment groups showed improvements, but there was no significant difference between groups at either week 12 or week 52 in the total score on the positive and negative syndrome scale. However, at 12 weeks, the patients taking Olanzapine and Risperidone had lower scores for positive symptoms than the Quetiapine group, and the advantage for Olanzapine persisted at 52 weeks. The effects on cognition in the same patients are described by Richard Keefe and colleagues in their article, Effects of Olanzapine, Quetiapine, and Risperidone on Neurocognitive Function in Early Psychosis, a randomized, double-blind, 52-week comparison. The 3 treatment groups had similar overall improvements in cognition. At 12 weeks, the patients taking Quetiapine showed greater increases in verbal fluency and processing speed than the other groups. Quetiapine was also superior to Olanzapine for vigilance. Better vocational and social functioning at weeks 12 and 52 was related to cognitive improvement, but may have also been due to general treatment response. Michael Green comments on these findings in the editorial, Cognition, Drug Treatment, and Functional Outcome in Schizophrenia, A Tale of Two Transitions. Dr. Green states that research in this area is going through 2 simultaneous transitions. The first involves our view of cognition and functional outcome, and the second relates to our view of medications and cognition. Both transitions leave us feeling a little smarter and a lot more humble. Regarding the connection between cognition and functional outcome, we know from scores of database studies that cognition in schizophrenia is related to community functioning and skill acquisition. The the challenge has shifted from finding an effect to understanding it. To that end, studies have started to examine intervening variables between basic cognition and community functioning. Such proposed mediators include measures of functional capacity and social cognition. To successfully map the steps leading to functional outcome, it is necessary to adopt statistical methods that are quite different from more familiar hypothesis testing approaches. Instead, modeling methods such as path analysis and structural equation modeling can reveal underlying factors and mediating relationships by comparing the degree to which observed data fit predicted theoretical models. A second key transition is that we are less comfortable with pinning our hopes on antipsychotic medications as a way to achieve cognitive improvement. Optimism that second-generation antipsychotics would yield cognitive improvements has progressively been tempered as treatment effect sizes have progressively dwindled, possibly as a result of dosing factors or patient selection factors. At any rate, the high hopes for beneficial cognitive effects from antipsychotic medications are now hanging by threads. The article in this issue by Quetiapine, along with the cognitive results from the Katie study, will sever some of the remaining threads. The comparison by Keefe complements the Katie study by including patients in the early course of psychotic illness and by using lower medication doses. Studies of early psychosis patients have the substantial advantage of allowing the relationships between cognitive performance and community functioning to be examined without the potential confounding effects of chronic disability and social alienation. All three medications yielded modest improvements in cognitive functioning at week 12, and there were no differences among the medications. The effects at 52 weeks were not significant. One conclusion from this study is that we should not plan to address our unmet need for cognition enhancement with antipsychotic medications. An interesting feature of the study is the examination of the relationships between change in cognition and change in social and vocational outcome. Pooled across treatments, the partial correlations controlling for baseline cognition and clinical symptoms were small at 12 weeks and roughly medium at 52 weeks. Depending on one's enthusiasm or skepticism, it is possible to focus on the smallness of the associations or on their statistical significance. It is worth noting both. The fact that the associations are relatively small is to be expected for two reasons. One is that we do not have a clear pro-cognitive treatment effect in this study. Second, and more important, there is no psychosocial treatment component as part of this design that would facilitate translation of any cognitive benefits to the level of community functioning. It is unlikely that cognition enhancement will yield social and occupational gains in the absence of vigorous, non-pharmacological interventions that specifically target these outcome areas. All things considered, it is notable that even in the absence of these additional intervention components, the change scores for cognition and community functioning were somewhat related. It appears that we will need to look elsewhere to find cognition-enhancing drugs for patients with schizophrenia. The National Institute of Mental Health has developed initiatives to stimulate the development of new drugs for cognition in schizophrenia by building a pathway for drug approval. These initiatives are known as MATRIX, for Measurement and Treatment Research to Improve Cognition in Schizophrenia, and TURNS, or Treatment Units for Research on Neurocognition and Schizophrenia. Now that the pathway has been constructed, there is good reason to expect that the pharmaceutical industry will embark on it and apply their considerable resources to this critically important unmet need. This concludes the audio highlights of the July issue of the American Journal of Psychiatry. We invite you to refer to the online issue at ajp.psychiatryonline.org for the full text of these and other articles. Thank you.